I am Julia Resnick, Senior Director in the Division of Health Outcomes and Care Transformation here at the American Hospital Association. And I'm going to be kicking us off for today's webinar. Before we get started, just a few housekeeping notes. I know by now in 2026 we're pretty familiar with Zoom, but you'll see that there is a Q&A pod at the bottom of your screen. That's important. So we'll have time for questions at the end. So as your questions come up when you're listening to our speakers, please go ahead and put them into that module, that pod. My colleague Jordan Steiger, who's joining us today, will help facilitate the Q&A towards the top of the hour, and we'll get to your questions. We'll also be asking you to fill out a brief evaluation form at the end of the webinar, and these are just incredibly helpful for us as we develop future programming and resources. So today we're joined by two really wonderful speakers who I'm excited for you all to hear from. Dr. Rabin Dahal, who's Assistant Professor of Psychiatry at Yale School of Medicine, and Dr. Ann Bird, the Medical Program Director for Primary Care Mental Health Integration and Transforming Mental Health at Rady Children's Hospital. But before we turn it over to them, I just want to do a little bit of level setting about the work that we're doing in care delivery transformation here at the American Hospital Association. So you can see our care delivery transformation framework in this infographic, and it's meant to represent the many forces that are shaping care delivery across the healthcare ecosystem. As you all know, our healthcare system is incredibly complex with a wide range of stakeholders, processes, and motivations. And all of you are working within that complex ecosystem every day. And within that complexity are brilliant, hardworking, passionate people who are deeply committed to delivering excellent care for the patients and communities they serve. But even with that dedication, I think we all experience some friction in the systems. The strategies may not always be aligned across service lines or with community partners. And in many cases, the issue isn't that good work isn't happening, it's that really fantastic work is disconnected. So if we're really thinking about how to move American healthcare forward, we need to be thinking about health and care delivery in the context of this broader ecosystem. And our work around care delivery transformation is designed to help you as healthcare leaders see the whole picture. It highlights the interconnections across the healthcare ecosystem and points to strategies both in the clinical and the community settings that can help move care into the future and improve outcomes. And at the same time, care needs to be built on strong foundations, those principles that guide your mission and the operational infrastructure that helps care run smoothly. So in today's webinar, as you know, we'll be focused on one care delivery strategy that sits in the clinical settings arena, and that is integrated behavioral health. So after this webinar, there are a number of ways that you can continue to engage with our work on care delivery transformation. On our website, you can go to the Explore page, which includes a clickable version of that framework infographic that includes curated AHA resources and strategies that are tied to each component. We also have a discussion guide that's based on the framework that can help leaders like you start conversations about how care delivery strategies might help address challenges within your organization. And last but not least, there's an opportunity for you all to share your stories about innovative care delivery strategies and the impact they've had. Some of those stories may be featured on our website or social media, or it might even be you in a future webinar. So with that, I want to turn it over to our expert speakers who can talk about care delivery transformation and integrated behavioral health, and two different approaches to it. But Dr. Dahal, I'm going to turn it over to you to get things started.
Thank you, Julia. Can you hear me well?
Perfectly.
Hi, my name is Rabin Dahal. I'm an assistant professor of psychiatry and a consult psychiatrist, meaning by I take care of patients who are admitted to the general hospital where they have various psychiatric and behavioral needs. And I was lucky to be part of when I was in training, to be part of the behavioral intervention team at Yale. And then when I was in attending, I can see it progress over the years. And I'll be talking about our program here. I do not have any disclosures. So what does a typical psychiatric consultation look like? Um, what happens is in a hospital, if someone with mental illness develops any acute medical illness, they get to a hospital, they have a behavioral health crisis, or they have any psychiatric manifestations of the disease. And then at that point, reactively, consults are placed. And what we found was by doing that, the medical care for patients who had psychiatric illnesses was complicated, delayed, or sometimes the diagnosis was completely missed. And there was a bad outcome for both the patient in terms of delayed treatment, increased length of stay, or things like restraints, medications, things of that nature. Um, so, and that was not a positive outcome. So the stakeholders' needs were not met. What we found out was our standard consults were being requested late. When they were consulted, it was also not appropriate. For example, the patients who were more vocal about their symptoms or who were behaviorally dysregulated were getting disproportionate resources allocated to them, whereas someone who was silently suffering, for example, with catatonia or some of the toxidromes, would be missed. When the consults did happen, it was often late, and that led to we missed the opportunity window of opportunity to act, so that we could not shape the outcome of that consult in a positive way. And it also led to longer length of stays. And our hospital usually operates at or above capacity, and that led to a number of patients being boarding in the emergency room while we had a prolonged length of stay for our patients. And at that point, we had to rethink about how consults work. And that led to the proactive consult model. So what happens in this is all patients with mental illness, they get admitted to the hospital, are automatically screened for um, like mental health concerns, and we provide them with care before things happen so that we can improve patient outcomes and staff satisfaction and length of stay and other outcomes as well. And this model was borrowed from AIMS and the impact model from Jürgen Unitzer, which was in the outpatient practice, to the inpatient practice. So, who are in this team, the behavioral intervention team or the new or proactive consult team? The main person would be the clinical nurse specialist. By training, this person is equipped in addressing behavioral emergencies, behavioral dysregulations, also like implementing behavioral interventions. For example, if someone has an eating disorder and they have to be in a certain protocol in a medical floor, they are the expert on that. Their role also doubles up as in being the screener. So all patients who get admitted to the hospital, they are screened for potential mental health concerns that could be a problem down the road. And so they do the screening part. Um, for anything that is to do with um, referrals, outpatient referrals, referrals to the shelters, things that are to do with medical legal interventions. For example, if you have to go to the court for an involuntary stay, or the social workers would be responsible for that. The providers can be divided into psychiatric APRN, who would be providing the bulk of the psychiatric consults, also partly helping the clinical nurse specialist in screening the patients. The medical director is ultimately responsible for the whole service. And because this is a teaching institute, there will be psychiatric trainees that also provide psychiatric care. Um, so if we look at the roles of each member, again, the patient service manager is not someone who rounds with us, but they are in the individual patient floors, and they provide overall like administrative backup. But the main persons are again the main people being the clinical nurse specialist who screens, the social worker who deals with especially regarding disposition and psychosocial concerns, and the psychiatric providers. The goal of this proactive model again being to overcome the deficiencies with the reactive traditional conventional consultative model in which we are again identifying patients early on and providing them with interventions early on and not missing the window of opportunity. A very important part of that model is to provide education to the medical nursing team and the medical teams, and that happened at the level of each member. For example, the psychiatric APRN would be talking to the medical APRN. The psychiatrist would be talking to the attending on the medical service. The nurse specialist would be providing education to the nurses, to the nurse managers as well. And the social worker would be talking to the medical social worker with the um, court clerks or with the outpatient social workers as needed. Um, we did a pilot study in 2011 on first it was on one medical unit, which only had 26 beds. And the CL psychiatrist met on only on weekdays and reviewed admissions. And this was compared. So this was the population, and the intervention was the CL psychiatrist meeting with the medical team on weekdays. Uh, we compared that with care as usual on the unit that happened before this intervention. What we found was that 20% of all admissions, they had a psychiatric issue needing a psych consultation. And we found that 17% of them had a psychiatric issue with where the psych consult affected the length of stay. Um, it also increased the workflow for the psychiatrist. So the rates of consultation doubled from 11% to 23%. But the intervention reduced the length of stay by almost a day. So after encouraging results from this, we implemented the main study in 3 different inpatient settings. Now, the number of beds was 92, and we looked at a total about 2 years worth of data in which total patient visits was over almost 16,000. What we found was um, it reduced the length of stay for the patients as well as it was financially sustainable. And I'm going to talk about these outcomes in more detail in the coming slides. The early screening that was conducted by the clinical nurse specialist and the psychiatric APRNs resulted in 8 to 12 new patients per day. Now we're talking about 92 beds, so that's a lot of new patients that are screened positive. And who were these patients? So some of the patients would be, we would identify if they are transferring from inpatient psych hospital to the general hospital, whether or not they needed to go back. We could identify that on day one so that it would not be an issue like on day 5. Patients who were on psychotropic medications, did they need any adjustment? Say if someone had sedating medications and the doses needed to be lowered. It did not happen after the fact that they were intubated. We could act on that early on. Patients with history positive for trauma or abuse, or who had psychiatric illnesses, people who are undergoing or at risk of withdrawal, we identify that. We also identified people who had a prior history of challenging behavioral behaviors in the unit, uh, needing restraints or security to be called so that we could intervene in a positive way beforehand so that it was a good experience for both the patient and the staff. Not all patients who screened positive needed full psychiatric consultation. Those that needed got prompt psych consults. Some of them either did not meet that threshold or they could be quote unquote curbsided. So we could speak with the medical team about these interventions can be implemented right now. Some patients did not want a psychiatry service seeing them, so they could also be co-managed, but in a with the information or the support from the psychiatry service. We were also expedient in referring patients to outpatient programs, or if they needed inpatient psychiatric admissions, it was a smoother process. And it led to a better collaboration at the level of all disciplines. And the inappropriate and missed consultations were almost zero due to this process. So this is the chart showing the outcome study for length of stay. The one-liner is there was a reduction in length of stay by a little over half a day. Now, this is significant for a hospital that operates at or above capacity. And we found that the interventions were most effective in patients who had a length of stay more than 6 days. And that was statistically significant. The trend was throughout, but it was most significant for patients who had a length of stay more than 6 days. And one of the things that come up when people have a reduced length of stay is, are they being discharged too soon? Are their readmissions rates going to creep up? And that's, is that the trade-off? We found that in our study, the readmission changes were not compared to prior. So the benefits held, and that did not lead to increased readmission rates. Uh, we did not do like formal studies on patient outcomes and staff outcomes. But what we know anecdotally from staff and patients is that they had overall improved patient and staff satisfaction. We also had improved retention of staff on these units, which is otherwise it would be a high turnover unit. We had staff retaining longer, and 85% of staff they scored 4 to 5 out of 5 on a Likert scale for satisfaction. So it was well liked by patients and staff. Now, financial comparison for 0.65 days, the average length of stay difference, if we multiply that for the number of cases that we had, there is a potential incremental revenue of almost 700K. And with these studies, Dr. Sles and team and Dr. Desan, they have shown that BIT is a self-sustaining model. The net financial return, I'm not a numbers guy, so excuse me, but for every dollar spent, they generated $1.70 in return. So it was a worthy investment. So after the study, I think the most important factor in was that we extended this to all the medical and med-surg floors, and it covered both campuses of Yale New Haven. So we have 1,000-bed hospitals in one side, and a mile away there's another hospital. So it was extended to cover both hospitals. Now, in 2025, there was a severe budget shortfall, so they had some staffing issues, so we had to modify this team. But it did we did expand it to cover both campuses. And this model was replicated elsewhere by Dr. Oldham and his team at University of Rochester, at Johns Hopkins, and several other places. So it's not a one-off or something that is for the demographic of New Haven. It's across the country that this study holds. And these are the references for the publications and things. Thank you very much for your attention.
Thank you so much, Dr. Dahal. Dr. Bird, we'll turn it over to you.
Hi, everybody. You're able to hear me, I'm assuming.
Perfectly.
Great. Well, great to be here. Thanks for inviting me. Thanks for that really interesting presentation there. I think, we're kind of dealing with similar stuff in terms of wanting to really approach things from a team-based standpoint, right, with education and early identification. So that was a lot of what I was hearing. The slight change for me is that I'm going to be talking more about pediatrics and kids as a child psychiatrist and a pediatrician myself. I did my training on the East Coast and now based in sunny San Diego, California. But I think regardless of what state you're in, what's common across all states is that we're in this kind of mental health crisis for kids, right? So 1 in 4 kids depressed and anxious. Suicide, unfortunately, one of the leading causes of death in kids. And, the challenge really, sorry. the challenge really falls on our primary care colleagues and our schools to a certain degree, because that's where kids are being seen and where problems are being identified. You can see some of the statistics here of what pediatricians and primary care providers are seeing. But as we know, those providers often aren't getting the necessary training. And in practice, they don't perhaps have the resources and time to take care of those kids. This is a somewhat busy slide, and just to orient you guys, the top is the mental health continuum. So you can see outpatient all the way up to the highest level, which is inpatient. And then below is the physical health continuum with that very all-important primary care medical home base at the start of that. And then in the middle, you can see this visual, and that kind of just symbolizes, I think, the historical, infrastructural, and insurance divide between taking care of our brains and taking care of our bodies. And kids can kind of get lost in that chasm. And I think what we really need to have is to have a primary care medical home that manages the primary care needs of both physical and mental health of the whole child. And then utilizing those two continuums if the child needs more than a primary care level of care. And in that situation, the hope is that this kid doesn't get lost in that chasm. And luckily, that's what we were able to do at Rady Children's. We were able to really, with a very generous philanthropic gift, take a look at how we were taking care of kids and try and transform that with partnerships and in collaboration with our provider network. And what we did is we placed a therapist in the office with the pediatrician. And we were able then to identify mental health concerns early, use a population health model, be generalist, seeing pretty much all and any mental, developmental, or emotional concern that came into the pediatrician, and do that in a cost-effective and evidence-based way. We really were hoping to work towards doing this at the sort of highest level of integration. I'm sure you guys will have seen the SAMHSA level of integration from coordinated through co-located to full integration. So, you know, what level 6 really means on a kind of day-to-day basis is that that therapist works in the office next door to the pediatrician. They're using the same EMR. They're communicating with the same front desk staff and the same MAs. They're seeing the same patients. They're putting their lunch in the same fridge as the PCPs and everyone else that works at that clinic. So that's what we've been trying to do. And just to kind of span out a little bit for you guys to understand kind of our model, we have what we call a hub and spoke model. So our spokes are those primary care sites, each with what we call an integrated health therapist or an IHT. And then knowing that kids who are being seen in that primary care clinic often are going to need perhaps more than just a couple of sessions, because they can only get 4 to 6 sessions there in the primary care spoke with the IHT. They may need more than that. They may need to see a therapist for slightly longer, up to 12 sessions in our hubs. They may need to see a psychiatrist, myself being one of them. They may need some care coordination help to get them into those higher levels of care. So we built out these behavioral health integrated care hubs that those spoke sites feed into. This is just a map of our locations so far. So we've got 10 at the moment, soon to be 12 actually, primary care clinics. And then we have 4 of those hubs that I talked about. And we span about 100 miles all the way from up here, our hub in Hemet in Riverside, all the way down to our hub in Chula Vista, right near the Mexican border. We've got another hub here in Mid-City in San Diego, which is actually where I'm sitting right now. And we've got a hub in Encinitas, North Coastal, and our primary care PCP sites feed patients into those hubs. I do want to say also that we're able to do this because of a very close affiliation with Children's Primary Care Medical Group, which is the second largest pediatric primary care provider actually in the country. They have about 30 sites across Southern California. So we're in about 10 of those. And so, the hope is to be able to keep expanding into those and cover more and more patient lives. I'm going to talk just a little bit about what our therapists do and what psychiatry does in the program. So our therapists that we call integrated health therapists or IHTs are both in those primary care clinics, and also some of them are in the hubs. Um, they are providing kind of quite short-term evidence-based solution goal-focused treatment, up to 6 sessions in the primary care site, up to 12 sessions in the hub. We also do some group treatments as well. And they're really there to be available for the pediatricians to receive warm handoffs on the kids that they're being seen. And then to, as I mentioned, kind of provide skills, brief psychoeducation, when possible. Warm handoffs are really a huge key to our program. That's our kind of front door into our program. Pediatrician sees a kid, can be coming in for an annual visit, can be coming in for a headache, can be coming in with a known behavioral health issue. And then they do a warm handoff with that therapist. So that warm handoff is a personal introduction between the PCP, the therapist, and the family. This has been shown to increase engagement. It definitely reduces stigma, right, for those families that perhaps don't want to go to another clinic and see a psychiatrist or a therapist, but they can see someone next to the pediatrician who the pediatrician trusts. They trust the pediatrician, and they can kind of have this engagement with this counselor to help them with their stress or help them with sadness that might be going on. And we ask in our program, we have a goal that of all of the referrals coming in, 80% of them come through in warm handoffs. Occasionally they get missed because the IHT might be out of the office that day, or the pediatrician is seeing that kid on a Saturday and we perhaps don't have a therapist there on a Saturday. So some of the time they get missed, in which case we catch them on the back end and we follow up with the family and offer them an appointment with our therapist. But warm handoffs have really led to increased appointments with behavioral health, fewer no-shows and same-day cancellations. It also helps the PCPs greatly as well. In terms of our psychiatrists, we have 3, myself and 2 others. We kind of live at the hubs, but we do a lot of our care through in-person or through tele. And we're also sort of providing short-term care. So we're there to help kids and help pediatricians with stabilization, with perhaps simplifying medication regimes, with some diagnostic clarity, and with helping kind of deal or handle an episode of care. And then those kids kind of get wrapped up and go back to the pediatrician for continued management. And then if there's an issue again in the near future, they can re-refer them to us. We have a very close relationship with all of our pediatricians, so we're able to help them manage their kids. Now, sometimes the kids are going to need more than being seen by a pediatrician. Perhaps they have a diagnosis that's a little bit more severe, in which case we get our care coordinators involved, and the care coordinators can help get kids into those higher levels of care. So as I showed you on that slide before, the continuum of outpatient and then intensive outpatient programs for kids, our care coordinators can help shift kids along that continuum if need be. People often ask me with this, not with care coordination per se, but about these different disciplines, what's the ratio? So I did want to mention our approximate ratio is for 1 therapist to 4 PCPs, so 1 to 4 or 1 to 5 ratio. You can also think about it like what the ratio is between therapist and the patient population. So for psychiatry, for example, a 1.0 psychiatrist, we guesstimate to cover about 50,000 patient lives. So the other thing I do want to mention, something that's kind of unique, I'd say, to our program and kind of speaks to, I think, a lot of what we're all knowing needs to happen in order for care to be delivered in the best way for our families and for our adults out there, is this being a team-based approach, which is obviously what we're trying to do here. We think of our PCPs as the quarterback of our team, and then our therapists and psychiatrists kind of wrap around that primary care medical home to support the pediatrician taking care of their population. And one way that we found to do this is through team meetings, or what we call registry conferences. There's two different models for integrated care. There's either the collaborative care model, or there's a primary care behavioral health model. We have more primary care behavioral health, which really focuses on warm handoffs and a generalist approach, all and anything we see. But what collaborative care model does is it runs these registries where a psychiatrist or other team members help run the list basically with the PCP, and kind of step in and help out with kind of suggestions. So the way we kind of do this is we have these team meetings where the team, the therapist, the care coordinator, the psychiatrist, all of the pediatricians at that site meet every week for half an hour, 45 minutes, normally over lunch on Zoom, with Epic pulled up. So Epic is our EMR, where we can talk about the kids that have been referred, the kids that have gotten a warm handoff, kids that perhaps need to see psychiatry, kids that we're struggling to outreach to and get back in, kids that we're concerned about who are high risk, kids that we know need to have a higher level of care. And we're talking together as to how, as a team, we can make those things happen for our families. So it's very quick, it's very efficient. We try and stay as organized as possible. And we really just run through those kids that we really need to check in on together. Communication is happening throughout the week through Epic messaging to keep everyone on track with who's helping who with what kid, and we can obviously read each other's notes. But this is a way of us all getting together, so we can actually flag kids in Epic and then know to talk about them. The reason I talk so much about this is because I really feel like this is where the magic of integrated care happens on these team meetings. So for each site, we have a team meeting a week. So right now we have 10 primary care sites, so we actually have 10 meetings a week for our team, and that will increase as we increase. I'm going to just mention a quick story just to highlight and show kind of how this model works. I'm going to call this kid Lucas. Lucas came to his pediatrician. He had a headache. Pediatrician did a PHQ-9 rating scale and a GAD, which is an anxiety rating scale, found out he was actually pretty depressed and suicidal. And then this slide, again, a little complex, but you can see the top line is our integrated care model, and our bottom line is care as usual. So in our integrated care model, you can see the PCP identified the need on day 0. They did a warm handoff to our therapist. Lucas came back for an initial with that therapist in the same office, day 8. And by day 36 and the 4th visit with the therapist, he was doing a lot better, and his depression and suicidality was improving. If you take care as usual, what's happening in some of the other clinics that don't have our model is the kid may still be identified, but then the family often just receives then a list of potential therapists in the community that perhaps are covered by their insurance that they need to call themselves to try and get scheduled. Now, our wait time in our community right now is about 6 to 9 months. Some places it's a little less, and I think there's a lot of work that's being done on that. But that's how long Lucas is potentially going to have to wait in order to get in and see a therapist. And as we all know, those kids oftentimes can get worse. They can end up in our emergency room, or even worse than that. So again, we're just back to prevention, early identification, early intervention, early recovery. So that's just an example of a kid moving through our model. All right, in terms of the sort of demographics of the kids that we find that we're seeing, it's like the big 3: depression, anxiety, ADHD are the main that we see. We see a lot of kids who have autism, and we also see a lot of kids that have had trauma. Sometimes those are sort of secondary diagnoses, but the 3 big ones are anxiety, depression, ADHD. And then you can also see a breakdown here of the ages that we see. So obviously we sort of want to see younger, because younger means we've caught them earlier. So seeing a lot of elementary school kids and middle school kids is a good sign that we're getting in there and we're providing these services to the kids when they need them. So in terms of our outcomes, yeah, I mean, so we've been open for about 5 years at this point. And we've seen, at this point about 15,000 kids and, done a lot of visits. I think our wait time is what I'm very proud of, which is that getting into a therapist. Now that's after the warm handoff, right? So they've done the warm handoff, that's day 0. But then getting in for that initial appointment about day 6 for therapy, about 9 days or so for psychiatry. So pretty good stuff already in terms of access. I threw this up here because, it's all about kind of monitoring and keeping check of how things are going, especially as our program's getting bigger and it's becoming more of a network. So we definitely are keeping track of, our appointments and our location comparison, our referrals, our template utilization, as well as the measurement informed care that we're doing that I'll talk a little bit more about in a second. And we get a lot of weekly sort of metric report outs on how things are going and how many referrals are coming in from where, what our no-show rate is, what our cancellation rate is. So just wanted to throw out there that we're kind of really keeping track of that so we can keep this as efficient as possible and continue to do our kind of continuous quality improvements. We were able to take a look at some of the measurement informed care and do some research into that, and found that of our kids that come through our program, 68% had a decrease in anxiety symptoms, 69% for depression. There's a 75% on average improvement in the clinical global impressions that we do every single time we see a kid. We were also able, with a small n here, it was at the beginning of the program, but to find that there was a reduction in mental health ED visits amongst the kids that went through our program. That's something we'd love to dig into more to show the kind of cost savings in the future of getting in there early. And then program satisfaction is another aspect that we look at, and found that, people in general are pretty satisfied, both the patients, the parents, and the providers with this program being in place. I will say I want to mention that the measurement informed care, we do a PHQ-9 and a GAD, anxiety and depression, for every single kid at every single visit. So we can monitor that for clinical improvement, and it helps us see where our program is lacking so we can implement training for our team. These are some patient and provider experience kind of testimonials, which I also just wanted to share. But I know I'm kind of running out of time, and I did want to talk a lot about our successes and our challenges. So, it's been a big journey. Like I mentioned, we've been open for 5 years or so. These were the big successes that came to mind. All of them I believe to be important to have a high quality integrated care program. The champion PCPs is key. Engagement from the PCPs to support the shifts that need to happen at that particular site. So that was something we prioritized, and I think has been one of the reasons why we've been able to be successful. Warm handoffs are also key, reminding everyone that we really are a team approach to this. Measurement informed care, as I mentioned. And then I'd say billing and reimbursements. We had to create and implement pathways for medical and private insurance payers. And we've been able to add dyadic care billing and community health worker billing for our care coordination services. Challenges. Everything on the previous slide was and is a challenge. And then there's these challenges as well. So the major one, no surprise, is fiscal sustainability. So mental health has really not been recognized by payers for many years in the way it should be. And I believe we've started to address the tip of the iceberg, but I think there's a lot more that needs to get fixed under the surface. Underpayments, insurance barriers to authorize payments, benefits are not updated. There's a lot of paperwork and administrative burdens as well. So that's all big challenges to pursue ahead. I think recruitment was a large challenge for us, of providers that have skills and knowledge in integrated care. A lot of people are taught traditionally, so that culture shift to the fast-paced primary care environment, the short-term nature of the work, that generalist approach, meant that we really had to retrain all of our new therapists, as well as psychiatry and our PCPs. And then future state, we again have been lucky because we've been able to secure another philanthropic gift in order to expand and scale to 6 more sites. But other areas for future growth is in education, which really I think needs to be multi-pronged. So we do a lot of patient education, provider education, workforce development education, like I was talking about before, and then trying to get out there into the community and help educate the community. So education, scaling and expanding, and then I'd say finally advocacy to really address that siloed system that I was talking about and require parity for mental health services, and really just promote the concept that integrated care should become the standard of care, so these kids can get help quickly. And I think the way to do that is through these kinds of things, and through partnerships and through more research and through policy work at the local, state, and federal levels. So thank you for listening. And I wanted just to leave an email there if there's any questions.
Dr. Bird, thank you so much. And I know there was a question that came in about if the slides are going to be shared, and they will. So you should have Dr. Bird and Dr. DeHaal's contact information at the end. We did get a few questions in the chat, so I'll start with these, but please, as we're going through, if you have any more, please submit them and we can get them answered. But Dr. DeHaal, to start with you, we had a question about the screening tools that you're using. So what is your initial screening? Is it homegrown? Is it something else? Could you tell us?
Yeah, so it is mostly homegrown, but with influenced by the impact model at AIM. So that's the model by Dr. Jürgen Junutzer, so he was practicing in Washington State. Half of the counties there do not have a psychiatrist, so it has to be by it has to be a collaborative care model. So we're trying to implement that in our system. So what would be the ones that would screen automatically positive are the obvious ones, right? If someone is transferring from the inpatient hospital to the general hospital, that would be one. If someone is presenting on day one with suicidality, homicidality, if they have any like personal care companions or sitters, if they're needing that, if they're needing PRN as needed medications to manage some of the behavioral concerns, they would be people who had a diagnosis of catatonia, for example, would automatically be screened. And it so initially we were and it's also a moving thing. So if we notice that people are missing from the screeners, we would modify that as well. To answer the question again, it is with heavy influence from impact and aims. It was with our homegrown screening. Yes.
It's great. I mean, those are great evidence-based models. And I'm realizing I didn't introduce myself to the guests here. So I'm Jordan Steiger. I'm the Director of Behavioral Health at the American Hospital Association. So that's why I'm here to talk about behavioral health a little bit more. Dr. DeHaal, to kind of add to that, so you're talking about who is initially screened, but after that, so what is like the threshold that would meet a psych service need? Like, were there specific items or scores that made it, like, yes, this person needs to be seen by a psychiatrist, or no, they can see a lower level of care?
Yes. So there are some things that were automatic. For example, if someone was on clozapine, someone was on lithium, so our heavy duty medications, right? So they would screen positive. So they would be seen by psychiatric provider, either an APRN or a resident or fellow. And then so that the levels and everything that would need to be modified happens on day one and not on day three. Um, people who we had known or say had catatonia, they were on high doses of lorazepam, for example, they would already screen positive. Um, People who needed personal care companion, because that was one of our that
Mhm.
was tied to one of our outcomes as well. Like, people who needed like a within length of arm sitter, they would already screen positive. And others, it would be a from reading the chart and seeing how complex they were. It might, so if it was someone who had a difficult interaction with the nursing staff, it could be at the level of the clinical nursing specialist could go and say someone had paranoia and they were not taking their food because it was, they wanted a certain type of food. We could engage with the nursing staff and say, okay, can we get from dietary packaged food only so that, we do not disrupt someone's paranoia while they are also engaging with us, right? But at the
Mhm.
same time, if someone had punched the nurse in question, that would be a full psych consult.
That makes total sense. So really just taking it patient by patient, it
Hmm.
sounds like, and making that assessment and that call. That makes sense. Dr. Bird, this came in during your presentation, but I'm sure both of you could speak to this. But you spoke a little bit about philanthropy and collaborative care codes and for billing. But how are these services billed and paid for? Is there anything else you'd add?
Uh,
Uh,
Sorry,
oh, go
Dr. Bird,
ahead.
go ahead. Go ahead.
Dr. Bird, go ahead. Yes.
Sure, you got it. So no, we bill sort of traditional behavioral health CPT codes, so psychotherapy for the therapist, E&Ms for the psychiatrists with add-ons. So we're also able to do in California for under 21s through Medi-Cal
Mhm.
dietic codes, which are preventative codes for addressing behavioral health conditions in kids. So we are able to bill for those codes as well. And we have recently added on billing for community health workers for those care coordination services.
Great. Dr. Dahal, what about you?
For us, the services were our staffing, the FTEs, the full-time equivalents, were paid for by the medical teams who felt that there was a need. So our services were actually, so for example, if cardiothoracic surgery didn't feel that they needed our services, they would not get those services. But the med-surg floor that would need behavioral intervention team, they would get those services. So in return, they were getting the social worker support, clinical nurse specialist support. If someone had a behavioral emergency, we'd have like best codes and we'd go to those floors. So it was paid for by those units.
Oh, that's a really interesting way to approach that. I like that kind of that opt-in, and I'm sure
Hmm.
you get good buy-in from the
Hmm.
units once they see the return on how great these patients are, their outcomes are.
Right.
That's awesome.
And there's also a spillover effect. For example, if we are training, like our nurse specialist is training the nurses in how to speak to someone who has dementia and they are like constantly, they have to be reoriented constantly or they're asking things constantly, how to engage them. It does not just apply to that particular patient. That nurse has gained that skill and then they can apply that to other patients as well. So it's a spillover effect in even in the patients that we're not consulted on. So I think it was a good it had like good sustainability that way.
That makes total sense. Dr. Bird, this one came in for you. You mentioned screening kids that come in to the pediatrician for the PHQ-9 and the GAD-7 at every visit, I think. So how do you do that? Is it a manual paper and pen screening? Is it digital? How do you do that?
Yeah, it's a great question. Um, it's digital mainly, so it goes through the health portal for the kids. If they're 12 and up, then the kids have access to that. They can fill that in. If they're under 12, we actually do a PSE 17, which covers kind of some of the symptoms you may see in a younger kid, and then the caregivers fill that in. But yeah, it's done digitally through the MyChart. If they haven't filled it in, then when they come into the clinic, the front desk can provide them with iPads to fill that in. So it gets pulled up into their chart immediately.
Great, that makes it easy. Question for both of you, Dr. DeHall, we can start with you. So from an operational standpoint, what capabilities must health systems build to safely manage higher acuity behavioral health patients? It's a good question. And then you're on mute.
That's a good question. So I think it is at like different levels, right? So if we are thinking about developing a behavioral intervention team or something, I would start off with, from a systems perspective, how can we screen that ahead of time? And what is that screening going to result in? And people, they like this model so much. But at the same time, if you just screen, and we notice that with screening, we're not getting 8 to 12 new consults or screen positives a day. There has to be some way to manage that as well. So that has to be addressed beforehand. Now that in a resource-rich setting, we might allocate a person to do that. In a resource-poor setting, maybe we have to have some other novel ideas. For example, can we do telehealth for people who screen, we have the screener on site, and can we have telehealth to address some of that if they screen positive? That has shown, and I cannot emphasize enough the role of the nurse specialist, the clinical nurse specialist, and social workers in our team, that they were the backbone of the team, because they were excellent in liaison and in education, and it kept the ship running. So that should also be planned.
Great advice. Dr. Bird, what do you think?
It's a tough question. It depends, like Dr. Dahal was saying, on resources, really. I mean, in terms of optimally, the capabilities would be the full continuum, right? So for the kids, at least it would be in mental health, like outpatient through intensive outpatient, through partial, through inpatient, through residential, and then of course the emergency room or urgent care. Now that's not always doable, in which case I think partnerships with communities that can provide some of those resources to be able to funnel those higher acute kids in would be important. In terms of just within the team that I work in for the high acute cases, it's just making sure that the team knows that with those kids that are more risky, we're going to have to be more available, provide more frequent appointments and check-ins, and help handhold the families to navigate the system to get the kids into the higher level of services where they need.
Definitely. I think you both bring up a few really important points. First, just with community partnerships, when we're talking about, different levels of resources, I think that's a really good thing to kind of explore, because if you at your hospital or health system can't maybe provide some of those resources or services, there might be somebody who can. So really exploring what's in the community and how that whole spectrum of care maybe can be delivered not in the hospital, but just in the community. I think that's a great point. And then Dr. Bird, you bring up communication, in your presentation, having those team meetings. And I'm thinking about, in lower maybe resource environments, like that's still a great way, I think, to care for a higher acuity patient, just having that communication and that coordination. Even if you're not co-located with the behavioral health team, you can still find ways to communicate and collaborate. Great. One more question that we got, and this is a good one too. So asking about breaking down cultural stigmas associated with behavioral health and just behavioral health patients, and how can we kind of get over those stigmas to reassure people that behavioral health is just as important as physical health? Another big question.
Right, and I can share that with my experience in the general hospital, right? So sometimes people have multiple myocardial infarctions. They're in the hospital. They've not been taking their medications. They are depressed. And yet when we go in and talk with them, they're like, why is psych coming to see us? And then that becomes a thing. And then we talk about like, how depression is going to lead to like, poorer outcomes and other things. If we are seeing, so the stigma is also at different levels. So there's a self-stigma, there's a stigma from other providers there, so if one thing that in my limited field I found useful is that if they see us as part of the broader team in that collaborative care and we're all looking at improved outcomes for you, and there is more acceptance in so if we are say rounding together, for example, if say the cardiologist has an excellent rapport and I'm like, I'm a member of the team, I'm a psychiatrist, I want to listen to this, and after finishing their thing they step out and I start asking questions, there's more acceptance to talking about these things. Chances are that when people are in a general hospital, that's the first time that they are seeing psychiatry, so I'm also mindful in tailoring my interview to get the most data out and also to be most helpful for them and it would be different from something that I would do in an outpatient psychiatric clinic, so that they would be more amenable to doing that even after they leave the hospital. So yeah, I think collaboration, buy-in from the primary teams, and
Mhm.
rounding together. Yeah, I think that has been helpful for me. But it's a small chunk of population we see overall. So yeah.
Well, absolutely. There's that societal stigma and everything else that's at play outside of the hospital too. But I love what you just said about, making that good impression from the psychiatric care perspective. So they're maybe more willing and can see in the future that like this is not a bad thing. This is somebody that's going to help. I love that. Dr. Bird, anything to add?
Um, yeah, not too much. I mean, it's a big topic. I think being culturally sensitive obviously is extremely important in this field. I think for our program, it's the families often trust their pediatrician. The pediatrician's been there often since the very beginning, and if the pediatrician trusts the therapist and the integrated care team, then that kind of trust can kind of migrate across to the families. We use different verbiage sometimes. Don't say therapist, say counselor or wellness coach. Sometimes say stress rather than anxiety, sadness, not depression. Um, those kind of things can go a long way. So can in the environment that they're in, right? What the environment looks like in terms of being inclusive and accepting. So I definitely also think that like families like it when they know that we're all working together as a team. So whenever I see a child for the first time, I name the pediatrician. I say, I spoke with your pediatrician, Dr. So and so, and we had a talk about what's been going on. I'm just here to help. And, I think sometimes that helps with the stigma around mental health. Yeah.
Absolutely. Building trust, I'm hearing from both of you, is a big thing. Okay, last really quick question. Do you have success models for an ICU or emergency department collaboration that you could share?
For the ICU ones, yes. And it's still in the more traditional consult model. But what we've now done with the staffing changes is that we're going by teams. So a particular team of, uh, a psychiatrist, APRNs, trainees, and the nurse specialist are going to be dedicated to that ICU side. So when we have multiple patients that are being consulted by the same floor, we sometimes, do education and other things as well for them to identify, okay, these are the things that we want. One of the common things that comes up is and it's a very specific example, but someone who has catatonia who's going to be on, say, 24 milligrams of lorazepam, and time and again the nursing staff, because they're worried about sedation, they stop it, and that's the mainstay of treatment. We don't want that to be stopped, right? So, gathering everyone together and saying, okay, this is why we're doing this, and then this is why we shouldn't be stopping it unless there's like respiratory compromise, etc. Has gone a long way, and and some of the traveler nurses who come in also get oriented by their whoever is giving them the hand up. So yeah, but I believe Brigham and Women's they have started like a behavioral intervention team for their ICU. With Jordan Rosen, I believe, is leading that. So there are models elsewhere that are effective. Yeah.
That's great. Well, I know we are at the top of the hour. I want to say thank you, and I'll turn it back to Julia to close us out.
Thanks, Jordan. And thanks, Dr. Bird, Dr. DeHaal, for sharing your expertise and your experiences. I think this will be really helpful for our listeners as they're thinking about how to integrate behavioral health. So I believe if it's not in the chat already, we will send a follow-up email that has the evaluation link. Tell us what you loved, what you want to hear more of, and we'll make sure to work that into programming. Also in that follow-up, we're going to give a little plug about an upcoming conference that we have. If you like the conversation that we are having here, you love having it in person even more. This is our Healthier Together conference, which will be taking place in Dallas in just 6 short weeks. So for folks who are in population health or community health, or really just trying to think creatively about how to connect clinical and community strategies to improve health outcomes, this is the place to be. So thank you again, Dr. Bird, Dr. DeHaal. Really appreciate your time, and thanks to our participants for your engagement. We'll see you next time.